Hi everyone, welcome back. I'm joined here by Graeme. We're going to do the part 4 of the introduction to blood gas analysis. We're actually going to go through some examples.
Recharged after a coffee.
Yep. Now some of these are quite complicated. Please forgive us if we get a little bit lost, but we're going to try and follow the rules that we said that you should follow as well, and just talk through the cases that we're presenting. So
feel free to get a coffee in front of you.
Yep. So I'm also going to ask you to do a couple of things if you are going to try and work through these cases with us, is pause it as we go along and have a go at the case yourself. But also before you start, maybe print out or write down the normal values, because you need to use these when you are calculating all the rules or looking at everything. So that's normal. We've got them there. Just remember that if the patient's pregnant, it's slightly different, so they should have a mild respiratory alkalosis, which has been with compensation because it's a chronic condition. Those are sort of more normal values for a pregnant patient. When does that change? How many days after a woman's given birth does it go back to normal? Probably take a while, I would have thought.
48 hours or so. It's a progesterone effect, and the progesterone levels do fall
Yep.
reasonably quickly after delivery.
Anyway, so glaringly obvious metabolic disturbances or respiratory or metabolic disturbances are usually much greater than this small change. Right. And so once again, maybe just go through, this is my system, but it's as good as anything, which is basically make sure there's nothing life-threatening. Think about the oxygenation, then go through the pH and acid base, and have a look at the electrolytes, glucose and hemoglobin species, etc., because that gives you clues about underlying things causing problems. Now, I've taken this from anesthesiamcq.com, which is Kerry Brandis's website. It's a great, I think I referred to it in the other tutes as well. So these are the 5 steps that we've been using in these tutorials. So print this out as well if you want to, and stick it next to you. So the first thing, in real life though, the first thing you should do is make a clinical assessment of your patient. And that often gives you a bit of a clue. So if it's a diabetic who's come and collapsed, you're going to be thinking about diabetic things, aren't you? When you look at the blood gas. Or if it's someone who has just had an operation and woken up and they had lots of opioids, or you're going to be thinking about respiratory problems. So you should always consider the clinical histories as well. And there are some other things that you should look at as well with everyone, just to give you a bit of an idea. So have a look, see what their anion gap is, what their sugars are, whether they dipstick on their urine is showing ketones, etc. Do they have known renal failure? These are all sort of clues that are going to help you when you make your analysis. And print out these rules. So these are the rules we went through last time. Print them out or look them up on your phone. These ones here, straight off the anesthesiamcq.com website, but these are the Boston blood gas compensation rules. So type that into Google, and there's probably lots of websites that'll have these there for you, and you can refer to these when you're trying to assess compensation, which is the bit that I find the hardest. Did you find it the hardest?
Yes.
Yeah.
I find all of it a little hard, but
it is actually a little bit hard. So there's you ever heard about type 1 and type 2 thinking? That book you buy in the airport, Fast and Slow Thinking.
Thinking Fast and Slow. I bought that one at the airport.
Yeah. So thinking fast is like, you see something and you just recognise straight away what's wrong, and you don't even really have to think about it. It's sort of instinctive. And type 2 thinking or slow thinking is where you have to work through things, and this is one of those type 2 scenarios where you have to sit down and give yourself a bit of time to work through it. Otherwise, you just can't get your head around it, can you? No. I always have to do this.
Yes.
Okay, case 1. So this is a 19-year-old pregnant, insulin-dependent diabetic patient who has polyuria and thirst. She feels ill, and she does have a history of poor compliance, and she's come into your hospital.
Yeah,
So it's pretty. Already, you can, without even looking at blood gas, put your hand over it, and you can think in your head, what is this? What is this likely to be? Now, obviously, it might be something that you didn't expect, but you got plenty of clues in there, haven't you?
Exactly.
What are you thinking, Graeme, without looking at the gas?
I'm thinking, look, she could be septic, and she could be ketoacidotic.
Yep. So those are the likely things, aren't they? She's probably likely to have ketoacidosis. So let's just have a look at what the results show. Do you want to have a go at this one?
Yeah, okay. So the pH is low, she has an acidemia, the PCO2 is very low, she's got a respiratory alkalosis, her bicarb is extremely low. We don't have a base excess, but I'm thinking she's got a metabolic acidosis, and I'm going to look at the anion gap. The anion gap is that result of 136 minus 108. So that's 28. That's very high. She's got a high anion gap metabolic acidosis. Her urea and creatinine are slightly high, but her glucose is very high, and I'm suspecting she's got a ketoacidosis as the cause of her metabolic acidosis.
And her urinalysis, which everyone can pretty easily do, shows lots of ketones as well, doesn't it?
It does.
So yeah, I agree with you. That's basically what this case shows. So this is a patient who this isn't a shoot on DKA, but you've got to look for precipitating causes, don't you? So if the patient says, I haven't taken my insulin for 2 days, then that might be the only thing. But often the ketoacidosis is triggered by an event like sepsis or an infection, where you get all the stress hormones that activate the ketoacidotic process. So you've got to look for infections. So someone like this patient, you'd be looking for, do they have chorioamnionitis, UTI,
chest infection,
sepsis of something? Is there something else going on? Sometimes steroids that they get given by obstetric colleagues like Celestone and things like that might trigger as well. Okay, that's a good one. Shall I do this one?
Yes.
I actually wrote these, so I should know the answers. But the truth is, I wrote them a while ago.
Let me have a go. It's good for my brain. So you've given me quite a lot of information there.
Yeah. So these are all real cases that I've borrowed from places on the internet. So thank you for all you internet sites that have provided these.
Yes.
Mainly Kerry Brandis and Deranged Physiology, which is an ICU website.
I like this printout though. Did you get that off a website?
Yep.
Looks like one of our own blood gases.
No, this is a real printout of a patient.
Okay. So this is a patient with septic shock who's been resuscitated with normal saline. And just to remind myself and others that normal saline is a hyperchloremic solution of intravenous fluid. The pH is low, the PCO2 is high, suggesting a respiratory acidosis. The bicarb is low and the base excess is low, which again probably indicates that the primary problem may be a metabolic acidosis, but you've got a metabolic acidosis and a respiratory acidosis, so that's a bit odd. The anion gap, which is 138 minus 127 being the chloride concentration plus the bicarb concentration. So that's about 9, isn't it?
It's 138 minus 127.
So it's about 11.
12.
12. So that's a normal anion gap metabolic acidosis, which probably indicates either a loss of hang on, where am I going? Okay, yeah, so it could be a renal problem, it could be something with an iatrogenic problem, or it could be something to do with the gut. I suspect it's the normal saline that's been given has caused the metabolic acidosis, and the patient still has a problem with their respiratory system. I don't know if this patient's intubated, ventilated. The patient may be underventilated or may have another respiratory illness. That's
right. So they could be on a ventilator, in which case it's the person who's in charge of the ventilator who's doing the wrong thing.
I failed to mention that the lactate concentration is also very high, which would be in keeping with the septic shock situation.
So this is actually a really complicated one to chuck on you, isn't it? So it looks like there's 3 things going on. There's a mild respiratory acidosis, a metabolic acidosis, which is possibly lactate, but that should be a high anion gap. So there's also a mild degree of hypochloremic acidosis from the saline as well. Let's go on to the next one, because that is quite tricky. So what would you do? Well, you probably turn the ventilator up a little bit.
Yes.
The lactic acidosis, the treatment is to improve the circulation. So there's you're going to fiddle with volume. You're trying to volume resuscitate, fiddle with inotropes, vasopressors, etc.
Yep. Support
treat
the circulation.
The underlying cause of the sepsis.
And give no more high concentration chloride solutions.
That's right. Yeah. So maybe consider changing to a different solution. Yeah. And is there anything life-threatening? So we didn't look at that, do we? So the hemoglobin, that's fine, 13.2. The potassium's fine. Oxygenation is good. So PO2 of 324. Cool. That actually makes you think that they probably are intubated.
Ventilated. And
that's usually an ET tube. So
you could get there with a non-rebreather mask, couldn't you?
You could do, yeah. Whoops, Jesus.
But that would be about it.
Okay, I'm going to have a go at this one. So this is a patient who was attempted intubation in, I can't remember where it was. I think it was like the emergency department or something like that. And they couldn't intubate, and they were trying to ventilate manually while they're trying different techniques to try and intubate. So let's have a look and see what... Someone did a gas on them, so presumably they had an arterial line, or maybe they just did a gas, I don't know. So what does this show?
The patient looked like it had some circulation. That's a good thing.
So the pH, 6.95, that's severe acidosis, acidemia. So that's getting pretty low. The CO2 of 100, PCO2 of 155, it's a really, really high CO2, so that's a severe respiratory acidosis. The life-threatening thing that I've spotted, the PO2 is 35. That is not compatible with long-term life. Something has to be done about that immediately. And you can skip down and see that the SO2, or the SATs, on the blood gas sample, so this is not a pulse oximeter, this is the saturation on the gas from the artery, is only 46%. It's likely, well, we don't know, was this venous gas or a arterial gas, but it's with the severe changes like this, we just assume that it is arterial, and that's pretty bad. So they're not actually really oxygenating this patient, so this patient is likely to die or suffer irreversible brain damage if something's not done about that in the short term. That's probably the most striking thing, isn't it? So the acid-base disturbance is just of secondary importance, I think. If you saw this, you just forget about doing some type 2 thinking, forget about your fast and slow thinking book from the airport. This patient needs oxygenation stat. So fix the airway problem. But for the purposes of this tutorial, let's go through the acid-base analysis as well, because you can maybe, when you sit down later on, once you fix the oxygenation problem, you can have a look at it and try and nut through it. So is there a metabolic acidosis as well, or is it just purely respiratory? So we're going to go through that. So the bicarbonate is only slightly low, so that doesn't really indicate much in the way of it's probably just the CO2. Is it slightly low? Yeah, it is slightly low, so that's a bit unusual, isn't it? So it's got a brackets PST, so I'm not sure if that's like a calculated bicarbonate or an actual measured one. But the base excess, which I often look at, is minus 1.5, so that's within the normal range. So it doesn't really indicate to me, without doing the calculations straight away, just glancing at it, that there's probably not much of a metabolic problem. So let's go and have a look at the rules. So this is an acute respiratory acidosis. So what does it say? The bicarbonate will increase by 1 millimole per litre for every 10 millimetres elevation. So it's gone up by 110. So 155 is 110 over. So it should go up by 11. So the bicarbonate should be 35, shouldn't it? So I think on this gas machine has actually got a calculated standard bicarbonate. I think this is actually a machine that adjusts your bicarbonate, doesn't actually measure it. So maybe we should ignore it on this one, because I think that bracket P.ST is indicating something different to what our machines do. There's different ways of machines do things differently. Some of them actually measure the bicarbonate, and some of them just calculate it based on the variables, the CO2 and the pH.
Yes.
So we'll skip that. Let's do the next one. All right, this is a tricky one. I remember this one now. So we won't spend a lot of time on this, but what does this show?
What is this? So the first thing is the sample type is an arterial blood gas, and it says the FiO2 is 21%, which is the same as room air. The pH is very low, suggesting acidemia. The PO2 is very low as well, suggesting there's an acute problem. The SATs are less than 40% in terms of acute life-threatening hypoxic situation. PCO2 is very high, suggesting respiratory acidosis. Lactate's incredibly high, and there is no bicarb there. So I suggest it's combined metabolic respiratory acidosis.
What do you think about potassium?
Potassium's extremely high, 22. So that's unlikely to be compatible with life.
Yep.
A potassium that high would cause an arrhythmia, and the patient may have an arrhythmia that's responsible for lack of perfusion of vital organs in the body. like ventricular fibrillation,
Yep.
but it could be that the specimen is...
Okay, I'm going to jump in and tell you. So this is actually a sample from a bag of blood that's just come from the from blood bank, but it's quite good because you see some extreme acid-base changes. Interesting that the potassium's so high. So I had a patient recently who had renal failure, and every time they got given a bag of blood and various other things, they had severe hyperkalemia, and you can see why. So what happens is over time, as the red cells in storage undergo significant degradation and changes. So this is just an example that a bag of stored blood is not all that it seems.
So I shouldn't have read that first line that suggested it's an arterial sample.
That's right. Well, I guess the machine when you do any sample, that's the default printout. I should have covered that up, shouldn't I? Anyway, it's quite good. So remember,
very interesting.
So the hemoglobin concentration 212. So it's concentrated, isn't it?
And a lot of sugar in there too.
Yep. Which is what they use to try and preserve the blood, is it?
Yeah, it's the metabolite to help the cells live.
Yep. Okay. Respiratory problems in the PACU or recovery, PACU being post-anaesthetic care unit. Yep. Very American.
Very.
I'll give you a break.
No, this is okay. So the pH is low, suggesting an acidemia. The PCO2 is high, suggesting a respiratory acidosis. The PO2 is low. The SATs are low. I'm not sure if this is a venous or arterial sample, but if it was arterial,
I think it's arterial.
You'd be worried about acute hypoxia. In addition, is there a bicarb? Yeah, way down the bottom. Bicarb is raised, and the base excess is in the normal range. This is likely to be an acute respiratory acidosis causing the acidosis. Looking at this 1 to 10 rule for acute respiratory acidosis, normally you'd expect for a rise in CO2 by 10 millimetres of mercury to be associated with a rise in the bicarb concentration by 1 millimole per litre. The CO2 is up about 23, so 2.3 added on to the bicarb. Well, that normal range is up to 28. So yeah, it could be.
So assuming it starts at 24, you should be up about 26, 27.
Yeah.
But that's pretty close,
That's pretty close. So I think it probably is an acute respiratory acidosis. And we see these problems in the
What's
recovery.
the most common cause?
So either over-sedation with opioids, potentially residual muscle relaxation.
Yep. Or any other drugs that suppress the CNS.
Yeah, exactly.
Or someone with sleep apnea who's not recovering properly. Yeah.
Yep.
Perfect. Sorry for the quality of this one. It's a bit blurry. So this is a code blue for a patient with sleep apnea on the ward. Shall I do this one? So I'm going to look through this. So what do I say? Before you do the pH calculation, I always say look for a life-threatening thing. So the life-threatening things would be severe acid-base change. No, that's normal. A PO2 of 10. So crikey. The saturation of arterial hemoglobin is only 8%. That's pretty life-threatening.
Very low.
So once again, you probably almost should ignore everything else, put everything down, stop looking at this piece of paper and go and save the patient's life because they are profoundly hypoxic and are about to die.
Airway, breathing, circulation.
Sleep apnea, it's almost certainly going to be an airway problem, isn't it? Well, that's what your money's on anyway. But they're unlikely to, even if you open their airway, they're unlikely to be able to breathe properly with that degree of oxygenation in their brain. So you're probably going to have to do something about that as well. All right, so let's assume we fixed that, and then let's have a look at the other changes. So bicarbonate is low, so that indicates that's possibly a metabolic acidosis. Is that right? Yeah.
Yes.
Which could be acute or chronic, and the base excess is minus 2.7, which is within the normal range. So the lactate is high, so there is a metabolic lactic acidosis, and we could do the rule that Graeme just used, so 1 in 10. So the CO2 is about 23 higher than normal, so it should be The bicarbonate should be about 3 above 24, so it should be 27, but actually it's 19, so there must be some degree of metabolic acidosis as well. It's probably acute from the hypoxia.
Yes.
Good. Let's do the next one.
Okay, again, now I'm getting better at looking at the oxygen first. The PO2 is not abnormal. Well, actually it is, it's high. But I can see that the patient's got an acute abdomen and it's just been intubated. The patient is acidemic. The CO2 is in the normal range. The lactate's very high. The bicarb is very low. The base excess is extremely negative. And so this is likely to be a metabolic acidosis.
Yep.
Other concerns are in the potassium concentration being very high.
Yep.
Which
So you
could
might
put the
wanna
patient
address
at risk of complications of hyperkalemia. And this would be in keeping with a metabolic acidosis associated with the acute abdomen state.
Yeah, due to the lactic acidosis. And just maybe for, so let's assume that we didn't have a machine that measures lactate, and let's calculate the anion gap and differentiate whether it's a high or a normal anion gap.
Yep, absolutely.
Acidosis. So we sort of know the answer already, but...
Exactly, 135 less 14, that's going to be, how's my maths, 11, is that correct?
Yep, so the sodium's 135 and the chloride's 102 and the bicarb is, what was it? 12. So that's 100.
Oh, sorry,
114.
Sorry, so
114.
that's
So
21.
135 minus 114 is 21.
So,
So
that
is a high
anion gap, metabolic acidosis.
And the unmeasured anion, which is actually measured here, is the lactate.
Yep.
So it's a lactic acidosis, and that's because what's the most common thing in acute abdomen is like ischemic gut. Isn't it?
Yeah, exactly.
So part of their gut is dead and is not getting any oxygen, so it's making a lot of lactate. It's basically dying, and that's probably the cause, isn't it?
That is correct.
So they need so what this tells us, this patient needs a laparotomy in the surgeon to remove the ischemic bowel.
That is, a laparotomy and surgery may give the patient a chance of ongoing life.
That's right. So if you leave them with this untreated ischemic gut, don't resect it. It's like having a dead limb or any other dead organ in your body. It's going to poison you and kill you.
Yes.
Right. So that's very useful.
Tricky.
Case 8.
Unknown ingestion.
Unknown ingestion. So not a common thing in obstetrics and gynecology, but it's just we do have patients
we have increasing
who inject themselves with things, or lots of people do try and self-harm, do silly things, etc. So not impossible. Let's have a look.
Okay. So
shall I do it or you do it?
I'll have another go.
Yeah. You're a good keen man.
Oh well, yes. The oxygen levels are not low.
Yep.
Although the stats of 92% are a bit of a concern. The pH is low. This is an acidemia. The CO2 is in the normal range. The bicarb is extremely low. And the base excess is extremely negative, suggesting a primary metabolic acidosis. The anion gap measurement, sodium 151 minus the sum of chloride 111 and bicarb 8, 119, is very high at about 32.
Yep.
And I can see that, I think there's an indication that the concentration of lactate is extremely high, with arrows going up.
It hasn't actually measured anything, so I don't know what that means.
So we've got a high anion gap metabolic acidosis.
That's right. So normally you should have respiratory compensation. So something is stopping that
without
patient.
respiratory compensation.
Yeah. So
there is a
CO2 is only 43.6, isn't it? Most likely scenario here is actually the patient's been intubated, I think, and the person who's intubated them hasn't set the ventilator appropriately.
Yes, to blow off the
So before
CO2.
the patient got intubated, they were probably hyperventilating and had maybe a very low CO2 and maybe somewhere between 10 and 20, I'm guessing. That'd be a good guess.
Yep.
Because usually people can sort of mount that sort of ventilation. And then what's happened, because they're so unwell, or maybe whatever they've ingested is also knocks off their brain. They're either hypoventilating or after intubation the ventilator hasn't been set high. It's just been set at a standard rate.
I remember salicylate ingestions can cause a mixed alkalosis acidosis picture.
Yep.
but I can't remember
I think it's the
specifics.
metabolic acidosis, but the salicylate initially can cause a respiratory alkalosis and stimulate breathing.
Yep, that's right.
Yeah, but the
I don't think that's
the
the
metabolic
case here.
component is what. Yeah, so
Yeah.
I actually can't remember. I got this from Deranged Physiology, and I think it was some sort of hydrocarbon ingestion. I can't remember.
Yeah, okay.
It doesn't really matter. We're just practicing
Yeah.
going through the gas.
Yep.
So let's do the last one. So this is a woman who had a cesarean, and she's getting intravenous morphine for
Yes.
pain relief. Is there anything else?
Well, we've already mentioned that you'd expect a compensated respiratory alkalosis in pregnancy. Here, her arterial blood gas already indicates an acidemia.
Yep.
The PO2 looks normal, although she may be on supplementary oxygen treatment, but the PCO2 is very high. With a bicarb that's a little low, but that may reflect the fact that she is pregnant, and this is an early identified blood gas change.
Yep.
With respiratory acidosis.
Yep. So we can go through the rules, but what we're thinking is that she should have at baseline a mild metabolic alkalosis, and then someone does something like IE operates on there, and then gives her morphine, and so superimposed on that she now has a metabolic acidosis. And that might explain why the bicarbonate...
Respiratory acidosis.
Oh, respiratory acidosis, correct.
Yep.
So that might explain why the bicarbonate hasn't
Not gone up.
gone high, because it started low from a pre-existing pregnancy-related bicarbonate level. All right, we could go through all the rules and things, but let's, in the interest of time, move on to the last one. All right, this is actually the same patient that we presented at the start.
Back again.
Just back again, because this is good. I'm going to do this
Things
one.
look worse.
Yeah, I'm going to do this one. So this is the second presentation. So severe acidemia, pH 6.93. The PCO2 of 10 shows marked hyperventilation, which is respiratory alkalosis. So she's trying really hard to compensate for the acidemia. Bicarbonate of 2, that's incredibly low, isn't it? So she's got very, very low. She's got severe metabolic acidosis with a very high minute ventilation or respiratory alkalosis trying to compensate. Her anion gap, 140 minus 2 plus 111 is 113. So 140 minus 113 is 27. Is that right?
That's correct.
So that's a high anion gap metabolic acidosis. She's got a hyperglycemia, so she's probably got ketoacidosis again. You can measure the lactate. She might, if she's severely shocked, she might have lactoacidosis on top of that as well. And should we do this one? Oh, this is complicated.
Oh, this
isn't it?
one's going to be a tricky one.
Actually, this gave me a fright. I didn't know I had 11. That's not a round number.
No, the history.
Shame, Roger.
The history's a little bit complicated. She's old. She has pneumonia. She has a heart failure, and she uses diuretics.
So what are we thinking? Without even looking at the gas, we're thinking pneumonia and heart failure. She's probably got respiratory problems, like respiratory acidosis, and then diuretics we know can cause a metabolic alkalosis, can't they?
Yeah, and we're suspecting a metabolic acidosis perhaps with a heart failure. So,
but then if she gets shocked, she's got bad heart. If she has some sort of degree of shock, she could get like renal failure or lactic acidosis from poor perfusion of her body or her kidneys. So she could have so many things going on.
Exactly.
My heart sinks. I don't really
we
know what to
talked
do this
about
one.
the diuretics, didn't we, as well, about they can cause
That's right. Metabolic alkalosis.
Yeah.
So my heart sinks. This is going to be a tough one for you, mate.
At least we can think it through. The PO2's not terrible.
Yeah.
Yep. The pH suggests an alkalemia.
Oh yeah, it does.
The PCO2 is low, suggesting a respiratory respiratory alkalosis. The bicarb is high, suggesting a metabolic alkalosis.
Yep.
And that's probably what we have, a mixed metabolic and respiratory alkalosis.
Yep.
She has pneumonia. She's likely to be hyperventilating with that. She's on diuretics and she's losing or unable to compensate and change bicarb concentration. But she's got a very low potassium again, which is suggestive of potassium loss associated
that's
with
the diuretics probably,
or
isn't it?
thiazide diuretic use.
That's why her kidneys can't correct that alkalosis.
Yes.
So the fascinating thing here is that she's got a triggering event to cause a metabolic alkalosis, which is the diuretics, and because her potassium is low, she can't compensate. Her kidneys can't just pee off all the extra bicarb. They're trying to hold on to the potassium, and therefore they let go of the bicarb. It's complicated, and I don't think it's fully understood. But yeah, that's probably why she can't correct it. But the funny thing is, normally your compensation is to breathe less. Isn't
That's
it?
correct.
Whereas she's breathing harder, so she must have some degree of something stimulating her breathing. All right, I think we're going to round it up there. I'll finish off with a few take-home points. So just remember to go through things systematically. So have a look in the history for clues. Use a systematic approach. Don't try and remember all the compensation rules. Look them up, and look for life-threatening things first. That's your type 1 thinking. Glance through, find something life-threatening, stop and go and fix it. And then come back and spend a bit of time working systematically through the rest of the result to see if you've got anything else that you need to pick up on, and that usually means you have to slow yourself down and use some written prompts or a system to remind yourself to do everything systematically so you don't miss something. Okay, thanks for listening. Thanks, Graeme.
Yeah, thank you. Good luck.